Everyone, and welcome to the TRI Research Translation Committee's Tuesday seminar. Today we are hearing about breast cancer risk factor that influence mammographic screening and the pathology of a mammographic breast density. And we're very fortunate to have with us today Adjunct Professor Thomas Lloyd, who's a Senior Staff Specialist with the Department of Diagnostic Radiology at the PA Hospital and a visiting radiologist with Breastscreen, Queensland, and Professor Rick Thompson, who's the Research Head of Faculty of Health for QT at TRI and a Professor of Breast Cancer Research. Before I hand over to Tom to start, I'd just like to acknowledge and pay my respects to both the Jaguar people and the Turrbal people, the traditional custodians of the land in which we are gathered today. I'd like to pay my respects to their elders past, present and emerging, and acknowledge all Aboriginal and Torres Strait Islanders here today. Also paying my respects to your elders past, present and emerging. Thank you. Thanks, Tom.
Okay, so thank you, everybody. That better? Thanks, everybody. So Tom Lloyd's my name. I'm a radiologist, as you've heard, at the PA Hospital, and have been working with, working radiologist, the phone doesn't stop ringing, and have been working with Rick Thompson for quite some time on mammographic density and breast cancer, which is an area that I'm quite involved with in a clinical sense as well. So the component of the talk that I'm going to do is essentially a rehashing of a talk that I gave at the Brisbane Cancer Conference a couple of years ago on the subject of mammographic density. And so it looks at the clinical issues of mammographic density, and then Rick's going to talk more to the science behind what it is and why it matters. So essentially, now unfortunately this slide is a little bit fuzzy, but essentially mammographic density is as simple and as complex as it's the white stuff on the mammogram. Now you have a variability on a mammogram between a breast on the left of the screen, which is almost entirely fatty replaced, and a breast on the right of the screen, which is almost entirely white on the picture. Now this is not something that the patient can feel. It's not the same thing as having lumpy breasts, but it is important from a clinical and a radiologic point of view. And the reason is that the women who have higher density in their breasts have a higher chance of getting cancer. This is the gist of a lot of the research that Rick will talk about shortly, where obviously there's something in that dense tissue that contributes to that, whether it be something that actually forms a cancer or whether it be sort of the fertile ground that the cancer can grow on, or possibly a combination of the two. But there is a known association between women who have a higher mammographic density and those people having a higher chance of getting breast cancer. But it's not just that, unfortunately, for these women, because the other effect, and this is the one that's most relevant to us from a clinical point of view as the people who read these studies, is that if you have a cancer, generally speaking, it's a white lesion on a mammogram. So if you have a white lesion on a black background, it's fairly easy to see, which means you can find that lady's cancer while it's quite small and she's going to do better. If you have a white cancer on a white background, as you can sort of see with the examples that I've got on the screen here, it becomes a lot harder to see. So these women, unfortunately, they have a bit of a double whammy situation where they're more likely to get breast cancer and we're less likely to find it. That's illustrated by this slide here, where what you're seeing is the sensitivity of mammograms for being able to pick up a cancer graphed against the density of the mammogram. So when somebody has a BI-RADS category A mammogram, which is what we see here, and you're looking for a white lesion on a black background, the sensitivity is almost 100%. So that drops off fairly substantially as somebody goes to having a very white background. So these women often end up being the people who present, as we describe it, as interval cancers. So what an interval cancer is a cancer that presents in between a woman's screening episodes. So she has a screen in 2000, let's say. She's due another one in 2002, but she develops a clinically palpable cancer between those times. And what we generally expect that is the case in those ladies, some of them will be genuine cancers that were not there at the first time point, but probably they were there. It's just we didn't see them. This is something that is increasingly in the consumer space as well. People know about it. This is the pamphlet or the headline from a consumer advocacy group, which is highlighting the fact that, you know, they want patients to know whether they have a high mammographic density. Unfortunately, it's not quite as simple as that. There's a lot of fairly emotional headlines about you must know your density, you must therefore know your risk. The problem is that we don't really have a good solution for what to do with these women. So if a woman has a high background mammographic density, does that mean that she should also be having ultrasound screening? Does it mean that she should be having MRI screening? What does it mean? And so it's an area that the US has gone down the consumer line. So they've mandated in many places that the patients need to know this. But the lead on from that is that if you're going to tell somebody that they have an increased cancer risk, but you don't have a next step for them, then that becomes quite problematic. And that's the scenario that we sit in Australia, where most of the screening is government funded. And so you can't easily say you should be having MRI screening, but we're not going to pay for it. So essentially you're saying you've got a higher cancer risk, good luck with that, off you go. That's not a good situation to be in either. So if you have increased density, that's important, but we need to know what to do with it. There have been a lot of studies on exactly this subject, as you would imagine, which are looking at the addition of ultrasound as part of a screening paradigm, as well as the addition of MRI as part of a screening program. And in both instances, what it has found is that there's an increased pickup of breast cancers, but there's also an increased pickup of a whole lot of other things that are not breast cancers. And so what that means from a government or a funding point of view is increased cost, increased false positive rate, potentially increased treatment of things that turn out not to be cancers, and that means decreased resources for other things. So throwing more resources at it without a good evidence base is difficult, which led to this statement, which was put out by Breastscreen Australia in 2016, which essentially says that at the moment we know that breast density is an issue, but we don't have good evidence about what to do with it and what advice to give people once they know that they have increased density. So therefore we're deliberately staying out of that space for the time being until the evidence gets better. Now, a number of studies, like I say, are looking at, there's a few different technologies that could potentially sit in this space. So one of them is called Thermosynthesis, which is essentially the 3D mammogram that people will probably have heard of. And it looks not dissimilar to a CT scan in that you scroll from the top down to the bottom or from one side to the other. You're looking at thin slices of the breast. What it does is it allows some of the overlapping structures to be removed because you're looking at things slice by slice. It does have an increased pickup rate. It does not have an increased pickup rate in the women who have very dense breasts. So in the people who have no breast density, tomosynthesis, the evidence shows, doesn't really make a difference because you can see it anyway. In the people who have the very dense breasts, tomosynthesis doesn't help because you just cannot see it at all. The ones in the middle, it does play a role. But a tomosynthesis study generates something in the order of 80 images for every mammogram. And when you consider that we do 4 mammograms per patient per episode. We've now got quite a lot of, over 300 images to look at per patient. When I do a screening board, is what they call it for Breastscreen. So I sit down, I've been given 100 mammograms to read and a certain amount of time and a certain amount of money to do it with. It takes me a period of time. If I then have to read 300 pictures rather than 4, it's going to take me longer, which means it therefore costs more, and you need more people to do it. You need more money to give them in order to make it. So there's always a cost benefit that works into this process. And I'm glad that I don't have to make these decisions at a government level, because, at some point a government might say, well, actually that costs more to do a screening program than it would just to wait for the cancers to turn up and then treat them when they appear. Thermosynthesis does work. So what we're seeing on this study here is that the pickup rate is increased, although, as you'll see here with the extremely dense breasts, not by much. The other thing is that the false positive recalls are somewhat reduced. So increased time and expense at the screening level, perhaps a little bit less at the evaluation level once those screening patients get passed on to the next step, which is we've seen something now, what do we do with it? But it's not perfect. Ultrasound is another modality which is also good, and it doesn't suffer from the same issues as mammographic density, but it finds a lot of things. And the problem is that you find a lot of things that perhaps are not cancer but do need biopsies and do need to be worked up in order to determine whether or not they need to be sorted out. And I thought this was important to kind of put it in context. So you'll see I've made one of the lines in this fairly wordy slide bold. So the cost effectiveness ratio, and this is for adding ultrasound as a screening modality for women with dense breasts, $325,000 per quality adjusted life year gained. So it's a lot of money for a relatively small gain. Obviously, if it's your quality adjusted life year, you're going to think differently about it than if it was somebody else's quality adjusted life year. But if you're talking about a population, then the challenge is, well, where else could that money go for that same amount of clinical benefit? And this is a challenge, and it's not a challenge that's going away easily. It's a challenge with ultrasound. It's even more of a challenge with MRI, because MRI is expensive and it's time consuming, and it does have false positives, although I would argue that if you're being read by people who are experts at knowing what they're reading, they tend to overcall less than people who perhaps don't. It is being looked at by a number of people around the world. There's a lady called Christiane Kuhl from Germany who is a big advocate in this space and is trying to improve the accessibility of MRI by making very short MRI sequences such that a patient can be in and out inside of 15 minutes, which is actually similar to a mammogram study. What it tends to do is it is very sensitive but not very specific. So you might find that something gets found, you have to come back for a second study, which will then look at it in more detail. But if it's negative, it's a good rule out test. The DENTS trial is probably the most important one at the moment. So this is run out of Netherlands, and it's a well-designed study that is looking at a large number of patients over a relatively long period of time. And when I first gave this talk, actually, I was describing the study and I said, it's about to report its data. And then I got a text message from somebody in the audience saying they actually published this morning, and here's what they've got. But so essentially, what they've done, this is a group that's looking at the people with the highest breast density. So this is the most severe masking effect, the BI-RADS category D, which is a relatively small proportion of the population. It's about 10%. But these are the people that we really miss things on. they looked at doing MRI scans on those patients, and then also the plan was to do it over 6 years over 3 screening episodes. And the reason for that is what you're really trying to do is you're trying to prove that doing a test, like a mammogram, like an ultrasound, actually improves the survival of patients. Finding cancers is one thing, but if you compare 2 groups of people, and this has happened with thyroid cancers, you look at 2 groups of people, you screen one of them and you find a whole lot of disease. You don't screen the other one. If it turns out that their survival is unchanged in both groups, then you're finding things that don't matter. And that's important with screening, because you have people who are not sick, you tell them that they're sick, you treat them for a disease that it turns out was not going to kill them, wasn't going to make them sick. Maybe your treatment will, but the disease wasn't going to. There probably is a component of the breast cancer space that sits in that area where the disease will not hurt you, but sometimes they're killer cancers as well. So you need to know that the cancers you're finding are important. The only way you can really do that, which is the study that nobody can ever do again, is to look at an entire population, to not offer the test to one part of the population, and then to see who dies more. That's not ethical. You can't do it. What you can do as an interim, or as an adjunct to that, is we're looking at interval cancer development. So we screen a bunch of people, we find a certain number of cancers, and then before their next screening episode, the real outcome that you're looking for is how many cancers clinically developed and became discovered before the next MRI study. And the assumption in that is that those are the ones that were missed, those are the ones that were growing, and therefore those are probably the killer cancers that should be being picked up by any screening program. So if you're comparing MRI screening to mammogram screening, what you would like to see is that you're finding less interval cancers in the MRI group, because you're finding them on the MRI, than you are in the mammogram group. These people have now published 2 of their 3 time points, and that is what they're finding. So from the first round, the prevalence round, so this is how many cancers the group of people who had not yet been screened by MRI had, 16.5 per 1,000, with a false positive rate of 80 per 1,000. The interval cancer rate, and sorry, there should be a slash on the second line of that, in the MRI group, 2.5 cancers per 1,000 appeared before the next MRI screening test, as compared to 5 cancers per 1,000 in the mammogram group. So that implies that the MR was finding more cancers than the mammograms were. The second round, which is the one that's been recently published, shows that the cancer detection is lower, which is actually what you would expect, because you found a bunch of them the first time. So what you're finding now is the ones that have developed since the first time. The false positive rate has decreased, which is important, because every false positive is something that needs to be worked up. And a lot of that is because whoever was reading those tests had an old one to compare it to. So they could look at somebody's scan and they could say, well, that thing was there 2 years ago. It hasn't changed. I'm going to ignore it. The first time when you had nothing to compare it to, you couldn't do that. So what this is showing is that in a certain cohort of people, MRI does work to find the cancers that are being masked by this mammographic density. What it doesn't address is how much does it cost and who's going to pay for it, which is obviously a difficult government decision. An MRI-guided biopsy, as I understand it, will cost you about $4,500 in the community, and you get nothing back from Medicare. So you're up for that cost in entirety as the patient. That's a lot of money. And it's a lot of money. It's a lot of money for people who have the money. It's an astoundingly large amount of money for people who don't have the money. And that actually does need to be sorted out in terms of, if we're looking at population health, where do we put our money? So I mean, that's the clinical problem of mammographic density. I tend to think of it as a masking problem primarily. When Rick talks, you'll hear he speaks a lot about it as being a tumorigenesis or a fertile ground, which it probably also is. there's something going on in the mammographic tissue that's more than it just being bland connective tissue, which is potentially a very fertile area for treatment, because if you can alter the mammographic density in a way that also alters the risk, then that's an enormous clinical benefit potentially, as long as you can do it in a way that doesn't carry risks in association. Obviously, if we can reduce mammographic density, we can have a more sensitive screening program. We can catch more of the cancers as well. So that the two clinical problems that we have is that mammographic density either causes or promotes cancers, but also that it stops us from finding them. And improvements in either of those areas will benefit patients. Okay, that's my quick run through. I think I will hand over to Rick. This is the current state of play with Breastscreen Australia, which essentially says we don't have enough information yet to alter the screening program. We're actively waiting for more information, at which time we may change things in the future.
Great. Thanks, Tom. Thanks so much, Tom, and that's really wonderful, setting the scene for what, as you said, we're trying to look at. I mean, some of you will know that I'm generally looking at the other end of cancer, what happens when it spreads and the invasion metastasis process. But I heard the talk from John Hopper in Melbourne about mammographic density as a breast cancer risk factor, that they had no idea how it was working. And I having had a background in extracellular matrix, I couldn't resist getting involved and interested in trying to figure out why. And it's been a really interesting journey, and a lot of it, as you've seen. How do you make those go forward? Hit the mouse. So I won't go over. I mean, obviously, Tom's really covered well, but, you know, both the fact that breast cancer risk, as indicated here in the highest quartile, is known to be higher. There's a number of factors that are pretty key and well documented. It's 60% of breast cancer has been shown to be genomically encoded from twin studies and sister studies. So it's hereditary. It's regulated by female sex hormones, so estrogen, progesterone, etc. It goes up, it goes down over menopause, and it goes up with HRT. It decreases slowly over age, but your rank in the density profile is consistent. So if all of it's going down over time and you're in the lowest quartile, you'll stay in the lowest quartile, etc. It can be measured accurately as shown there, but that's not, doesn't really account for the fact that not everybody measures it the same way. So introducing mammographic density measurement across a nation, for example, would be quite challenging still. The fact that it's estrogen regulated, and I'll touch on this, and Tom touched on it too, that it is an indicator of estrogen status. And so it's become interesting from the point of view of being able to predict or read out whether tamoxifen is working, both in the prevention setting and the therapy setting. And a very important thing to mention is that, sorry that I'm seeing mostly this, sorry, the people that are looking at that, but a very important thing to mention is that in thinking about mammographic density and breast cancer risk, you should really be thinking about the composite risk, all of the other factors as well. You can't think about it in isolation. So somebody who has high mammographic density, but other factors such as the number of children, the amount of breastfeeding, the age of menarche, the family history, the breast cancer genes, etc., need to be taken into consideration. But those are taken into consideration, and there's trials, as Tom mentioned, asking whether or not screening should be adjusted. Should there be fractional screening? So if you're in a low overall risk category, you could get screened every 4 years rather than every 2 years, and every 1 year if you're in a high risk, etc. So people are looking at that, and that may change over time. As Tom mentioned, whilst the risk for breast cancer, lifetime breast cancer is increased, it's much higher when you look at interval cancers. And so this is early data. It's probably not quite as high now with modern techniques, but 17-fold or thereabouts increased risk of an interval cancer that would be detected before your next mammogram, if you're in the highest quartile compared to the lowest. So masking is a big issue. And as Tom mentioned, we've been fascinated with why does mammographic density cause increased risk. And our approach has been, with the help of Tom and others and all the clinicians, to get hold of mammary tissue that's been taken as a prophylactic mastectomy and get a slice of tissue from the pathologist after they've cleared it and made sure it's okay to give away. And then we do a slice mammogram as shown there. On the there you see high dense regions and low dense regions and compare what's there. We cut it out and then we look at it histologically as shown here. This is old data, but it's consistent all the way through. You look at high dense tissue, the glands and ducts are the dark blue purple looking structures. And in the high dense tissue, they're surrounded by dense connective tissue, that eosinophilic pink collagen matrices, probably up to another 350 other proteins as well. Whereas adipose cells, shown the white circles, are directly abutting the glands in some regions, or there's certainly reduced density. So, you know, that kind of dense connective tissue fibrosis is a known prediction factor for cancer in many settings, and a lot of the factors that people study there may be happening here. That's tissue stiffness, mechanobiological effects, but also factors being produced by the stromal cells that might egg cancers on, interfere with their ability to inhibit oncogenesis, etc. So that's been, and here it's just simply to show that, yes, if you look at 43 different women, you find there is indeed statistically more stroma, connective tissue, less fat as here. And then also there is in our second study of 43, not in our initial study, slightly more glandular tissue as well. So that some people say, well, there's more tissue, more glandular tissue, more risk of breast cancer. So that's still a bit of an option. What we've done here with Tom and the team, we've now had 53 mastectomy accruals. I just checked up today. And on a Hugo, who many of you will know, who went to the University of Sunshine Coast earlier this year, and our student Schwan has been taking that tissue. And rather than assess it histologically, we've been culturing it on these sponges. So at the air interface on dental sponges in media, as depicted here. So these are 3 different low dense explants and 3 high dense. They look very much the same, but microscopically, even after 2 weeks, and this is pretty good. In cancer explants, they may really only usually last 3-4 days. Maybe there's more metabolic activity, but these are preserving their histological structure, and also their cell viability is preserved even up to 2 weeks. And it allows us to do manipulations and treat with hormones, treat with inhibitors, etc., which we've done. And we've done that in conjunction with a miniature MRI machine. This is the NMR mouse. This was Konstantin Momet's baby. He's a medical physicist from QUT and got interested in applying this instrument to mammary tissue, particularly to look for mammographic density. It's probably nowhere near as efficient for finding malignancy as clinical MRI, but maybe it's good enough to find mammographic density and quantitate mammographic density. So doing a mammogram every time you want to know the mammographic density is quite, quite a lot. You can't have repeated mammograms all the time. So this would give you the opportunity to do this more frequently. There's a lot of environmental questions that you could ask, etc. And this simply shows that you can clearly distinguish low dense tissue from high dense tissue with this NMR. It basically gets a readout of percent water. And if you plot the percent water from the NMR machine against an X-ray gold standard by micro-CT, you get a very strong close correlation. So we can put the tissue explant on the mini NMR initially and then look at that after the 14 days of culture. And so we've done quite a lot of experiments with different things, and I won't go over them in the interest of time, but in one area we've been looking at ECM and what are the factors in that matrix that might be maintaining and driving malignancy. And this study has been looking particularly at a proteoglycan, Syndecan, interacts with endocrines, is known to affect migration, etc. But if we interfere with Syndecan, it is upregulated in high dense tissue, it's estrogen regulated, And if we block its interaction with integrins, we see mammographic go down. There's a small peptide we use called synstatin, sorry. And it's modified by an enzyme heparinase. If heparinase cleaves the heparan sulfate side chains, that causes more syndican to be produced when the enzyme is added, or it would cause the reduce if we block the heparinase. And so there's a couple of ways there that we can manipulate that axis to have a reduced mammographic density. And similarly or separately, if we use hormones in those cultures, if we add an androgen, we see estrogen does sometimes cause stimulated mammographic density. These are the same explant before and after 2 weeks treatment with estrogen. You see they're mostly going up, but not always. We think that there's differences in the amount of estrogen available. But if we add estrogen and as well an androgen, such as a SARM, a selective androgen receptor modifier, or DHT, the steroid itself, it always reduces that. And so there's a possibility. And androgens are known, particularly by our collaborators, Tilly and Hickey in Adelaide, to oppose estrogenic effects in cancer. Not the developmental good parts of estrogen, but the nasty parts where estrogen is known to promote malignant growth, etc. And in fact, Steve Birrell in Adelaide, who did his PhD on androgens and breast cancer, is a surgeon with a clinic, and he's treating women with a combination of androgen and aromatase inhibitor, so it doesn't get converted into estrogen to reduce breast cancer risk in high-risk women. So this is sort of something that retrofits an already ongoing translational aim, but we have a lot of interest in both of these. There's a lot of questions to ask, but that's the sort of work we've been able to do with the help of Tom and the team in radiology. We have a new project, and this is related to John Hopper's observations that if you stratify and threshold brightness. And so most of mammographic density talks about what's on the left. I'm not doing well with this mouse. All of the white material, that's called mammographic density. But they've been saying, well, looking at breast cancer risk association, in fact, that if you look at all mammographic density, that associates best with masking. That makes sense, I guess, both in terms of interfering with the appearance of the cancer or the appearance of the cancer, but also interfering with some of the normal tissue effects that Tom and others, Tom and his colleagues rely on. But if you want to look at breast cancer risk per se, that seems to associate better with these very, very bright regions. And so we're just trying to focus in on those bright regions. And this is a new project to get the slice mammogram, dissect out those regions and compare micro-CT, NMR mouse, as well as histology at a very high level of resolution. And so this is ongoing with James, which is the TRI breast fellow, and Ian, his supervisor, Tom and Jill, and she's been amazing, a research nurse from radiology who's helped us with all 53 of those accruals, I think, and Satcher and Constantine and Anna. And also the TRI core, so it's Brian and Camille with the micro-CT and Justin with the histology. So just lastly, as mentioned, that there is an opportunity to see whether or not things like tamoxifen or other anti-estrogens are working. This came from a prevention study, the IBIS-1 prevention study, which proved that tamoxifen is a chemopreventative agent in breast cancer. And the only biomarker that they could see that associated with that response was mammographic density. They took biopsies, they tested things in blood, they tested lots of things. Only mammographic density change. So if there was a 10% change in mammographic density, tamoxifen was working, it was preventing breast cancer. The women who didn't have that reduction in mammographic density went on to have the normal rate of secondary tumours. These were women with one tumour already. And then others then said, well, what about tamoxifen as a therapy? And there's like 20 studies now of clinical cohorts where they've been treated with tamoxifen and they've looked at mammographic density. And by and large, as per this review we did a little while ago, if the mammographic density went down, the treatment worked. And so the women who didn't have recurrences had mammographic density going down. Women who did have recurrences didn't have their mammographic density going down. So could we use this as a way to predict response to tamoxifen? It's a 5-year treatment. So there's like 19,000 women a year getting breast cancer in Australia. 2/3 of those are ER positive. Many of those will be treated with a hormone therapy. and a third of those, it's known, won't respond. So that's about 4,000 women a year who may not be responding to their tamoxifen. If you could identify them, that would be terrific. Could we do it? Well, you know, there's a problem a little bit, is that we couldn't do a lot of mammograms. You can wait to that annual mammogram review, or you might be able to use the NMR mouse. And so we've done a small trial using the CRF facilities with the NMR mouse of 15 women. It's still being analysed, but you can see what sort of data we get here. Again, you see that you get a reading of percent water or percent fat, but we focus on the percent water. This actually gives you a reading at 2 millimetre intervals from the skin. So if you take the participant B here on the right, this is their skin. It's starting to give you a readout. 2 millimetres in, it's high. This is skin, actually has a lot of tissue. It's got a high water content. Then you get into the fat that's surrounding the breast glandula. It drops down, then comes back up. Participant A has a little bit lower density, so you can see that's lower. So the question would be whether we can see this longitudinally and whether we could see that 10% reduction accurately in a woman that we're looking at after she starts her tamoxifen therapy. So that's a very exciting project. There's a lot of other things you could do as well, but this is pretty much what we're focused on. We'd expect that would go up with HRT. We'd look to get those women in as well. So just in terms of our collaborative achievements and the requested final slide, obviously this has been a wonderful collaboration. I'm sorry that we didn't have a chance to elaborate more, but we have a really terrific partnership with Tom and also others there, particularly Jill, as I mentioned. Wonderful support from TRI and a SPOR grant initially, and then 3 years of funding from Prof has helped us really achieve quite a lot. It helps us, Tom and his, you know, understanding and work with Breastscreen and his understanding of the field allows us to maintain a strong translational relevance with an element of realism. I do think it's a great area for clinical trainees. We've had a number of surgical PhDs in the past. The translational goals, we used to say we want to prevent breast cancer. And I think that we're realising over time that that's very difficult to come up with a breast cancer prevention strategy. That's something that they're going to take. I mean, the uptake of tamoxifen, even a very well-accepted drug like tamoxifen used universally in ER-positive breast cancer, the uptake's very low. It still has side effects. It's a hormonal therapy. It's not a strong chemotherapy, but it still has side effects. And women are reluctant to do that. They'd rather have a mastectomy mostly, or wait until they'd be observing, you know, much more observant. So our translational goals have come back a step to be more proximal, and particularly with an idea of clearing mammograms. So, you know, whether you could have a short-term treatment that would reduce density just before you had your annual mammogram or biannual mammogram. And so you would have a more efficient mammogram. And also monitoring therapy response. If we could find that test would be able to show that 10% reduction in mammographic density, could that become a test that women would undertake when they're starting their tamoxifen therapy? I haven't really mentioned it, but you know, we have been involved with, I guess, advocacy around mammographic density. As Tom mentioned, it's legislated in 36 or 38 states in the US. It's a bit of a dog's breakfast. They all have different laws, and it's not really clear that it's helping. But there's obviously a lot of interest among women in this area, many of whom would like to know their density, but it's not simple. It's that simple complexity that Tom mentioned. So this has helped to have that balance from Tom in that area. Longer term, you know, it would be great if we could have breast cancer risk reduction. Maybe androgens aren't as bad, and they could actually help. And certainly that's what Steve Birrell thinks. Breast cancer progression, I didn't touch on it, but it does. Mammographic dense, or breast cancers that arise in dense tissue do progress faster than those with low dense tissue and response to other therapies. So I've touched on a lot of these people here as in the discussion as we went through. And maybe in the interest of time, I won't read them all out, but certainly there's been a lot of terrific collaborations and involvement of people along the way, and the funding, but particularly maybe just mention the others in addition to the radiology folks, the surgeons who've been providing this tissue, and the pathologists such as Linda and Simone, who make sure we get that slice of tissue without it going into formalin, etc. So I think I'll stop there in case there's time for a couple of questions, and be happy to answer them if there is. Thank you. Oh, tough. How does it? Got to check the chat. Any questions? There's one in Q&A.
Is there any trained AI that can help screening high number of images? Okay. AI is an interesting area that probably when we talk about AI or CAD, so computer assisted detection, which is mammographic.
Just for the people online, I can't see you.
Okay. Yep. It's a constantly evolving area, and so probably what was correct in the past perhaps is not anymore. The old adage with CAD for mammograms was one of the first areas that computer assisted detection / AI was employed for, and this was many years ago. The thinking at the time was that CAD would make a bad radiologist better, and it would make a good radiologist worse. And the reason for that was the CAD would throw up a whole bunch of possible lesions on a mammogram, which if you hadn't seen them, you would then potentially evaluate. But if you had seen them and you'd thought about it and dismissed them, the fact that the machine was throwing it back up to you made you overcall more than you otherwise would have. So if you were already a good reader, it tended to increase your false positive rate, and it wasn't helpful in that sense. That was the old iteration of computed decision support. There's a lot of work happening with AI in many areas of radiology, not least of which being mammograms, because there are such large data sets available. As yet, there is not a good clinical tool that is being used in Australia, at least, for screening mammograms. There is some stuff for MRI, but that is mostly based on how fast does something enhance versus the background tissue, which doesn't always equate to what is or is not a cancer. So look, it's a constantly evolving area, and I'm sure that it will have a big role at some point. But I guess the challenge is, and this is the challenge with AI in all areas of life, including, say, flying a plane, driving a car, etc., is you need to be confident enough that the computer is not missing things before you. So, I mean, if the computer crashes the car and kills somebody one time in 1,000, is that good enough? What if the person would have crashed at one time in 1,000 and killed someone? It's a difficult problem. And the other big issue with AI, in a regulatory sense, which is going to potentially hamstring a lot of the research or the clinical application, is who is at fault? So if you employ an AI to help you read a mammogram and it misses a cancer, did you miss the cancer and therefore you're liable, or did the person who wrote the code for the AI, did they miss the cancer? In which case, what if they don't live in the same country? What if they're not medically registered, etc.? Where does the fault lie? That's not something that's been sorted out by regulatory agents anywhere in the world, I don't think. And it's exactly the same question about if the Tesla crashes, who crashed the car, and therefore who's liable for it. We don't have answers for that stuff yet.
I could just add to that, though, that that at a research level, it's been quite helpful. And John Hopper, that I mentioned with the brightness study, has undertaken, as Tom said, it's a very fruitful area because there's just literally millions of mammograms around the place. And so they use 36 features, including brightness, and found about 7 of them, I think, were very highly linked to breast cancer risk. And so there is a whole new area coming. I think hopefully we can focusing on brightness and try to find out what it is that's so bright and why it's causing breast cancer or associating with breast cancer. But some of the others might be harder, the other textual features.
I think breast cancer, sorry.
Yeah. When we're looking at blue channel and fluorescence, we don't see collagen because the vibrates and it's harmonic. So is that just collagen floor that's giving you the brightness?
You're just asking about the collagen. It's very interesting. There is more collagen, but also the formation of the architecture of the collagen is clearly different. It's organized differently, and we and others have shown that. And it's one of our interests in proteoglycans because they have that role in remodeling collagen architecture.
With collagen, you don't need to put a fluorescence marker on to see the fluorescent microscope. You just see it.
I thought I'd never say that I couldn't hear you, Fiona, but
So you don't need a fluorescence marker to see collagen. If you put it in the blue channel, dark channel, you can just see it. It's got its own inherent fluorescence. Yeah.
Yeah, it's clearly collagen there, and it is pretty complex. I mean, it's probably for us to really know what the heck's going on with all that ECM and collagen. There's a plethora, so many different things you could look at. I started looking at stiffness just as an overall physicochemical parameter, and that's been quite rewarding. And we found some epigenetic regulation there. That's an area that you could pursue. But we thought that maybe, the proteoglycans and the slurpees, the small leucine-rich proteoglycans came up very highly in a proteomic screen we did. And they often have these roles in modifying the bundling and the appearance of collagen. So they can be targeted.
Ever screened molecular proteins like Trump's targeting rich that it matrix protein and cross-links the collagen. So if you look at the cross-linking proteins in there,
we've really just looked at that grey level concordance type of measures and, second harmonic, just overall physical parameters. And we just really looked at those slurps and then we end up with proteoglycan syndican 4 because it was so heavily associated in terms of the expression level with dense tissue, and it's primarily epithelial. So even though the amount of epithelium is only slightly higher in the dense tissues, the syndican 1 and 4 both were upregulated, but syndican 1 was then estrogen regulated as well. So we sort of focused in on that.
There was an interesting study done with so a lady called Connie Lehman, who's a radiologist in the US, who's quite academic and publishes a lot, was looking at background parenchymal enhancement. So when you give somebody contrast for an MRI scan, how much does everything light up versus just the cancer lighting up? And what they found in a study of high-risk women was that the people who had a lot of background enhancement got cancer at a higher rate than the people who didn't. So they thought, well, we're onto something here. There's something in the background milieu that's doing this. They couldn't replicate it in average risk people. So it's not just the density. There's something else happening as well, and it's probably genetic, and it's not just the stromal background.
Right.
It does, which is sort of my theory, which I have absolutely no evidence whatsoever to base it on. That the density or the background that you're planting your cancer in is either a fertile ground for something to grow in or not. And I suspect that there's a number of cancers that develop in the course of somebody's life, most of which will die on the vine because they don't have blood supply, they don't have hormonal support, whatever. But if you have the correct microenvironment for that tissue to then progress, and so it may well be that a number of the potential treatments or the potential etiologies for this, it's not the cancer itself, it's the environment that allows the cancer to grow. And it may well be that if we find something that can make the environment more toxic, then essentially you're stopping the cancers from ever getting to a level that you would be able to clinically find them.
We really just looked at that grey level concordance type of measures and, second harmonic, just overall physical parameters. And then we end up with proteoglycan syndican 4 because it was so heavily associated in a proteomic screen we did. And we thought that maybe, the proteoglycans and the slurpees, the So there's another question there on the chat from Colleen. Thanks, Colleen, about whether or not mammographic density changes with menstrual cycle. And it's a bit controversial, but generally no. I mean, most of the studies that have looked at it, but remember, it's not simple to look at that, you know, with serial mammograms. It's been done on population-based studies looking at lots of women in different, and knowing what stage of the cycle they are. It hasn't been done longitudinally to my knowledge, but the consensus seems to be, if so, relatively little, unlike, you know, MRI quality, which changes quite a lot during the menstrual cycle. Mammographic density doesn't seem to change. I don't know if X-ray is indicated as being better at a certain part of the cycle than others.
I don't know if anyone's looked at it, and the the challenge is as well that an X-ray, even one of as low a dose as a mammogram, which is quite a low dose, is still a radiation test. So it's an ionizing radiation, and you're potentially exposing a radiation sensitive part of the body to radiation in order to try to minimize the risk of cancer, or to catch the cancer. So there's obviously a problem there. If you screen too much, you could be causing the cancer rather than catching it.
Well, we better wrap up. Thank you for sticking with us. Sorry we managed to go over a little. We'd just love to talk about this stuff. And so thanks again, and look forward to chatting more in the hallways.